All right, there you go, recording. Hello, ladies. Hello, Dr. Joanna Walska. Hello, Kelsey Baker. I'm Dr. Beth DuPree, and we are coming together to discuss some things that I find incredibly lacking in my Western medical world that my colleagues need to know. And I wanted to bring my granddaughter and daughter-in-law's team of experts to the table so that we could talk about folic acid, 5-methylfolate, tongue ties, ankyloglossia, um, breastfeeding, nipple shields, the whole gamut of things. And we're just going to kind of go for it. And I hope that everybody who gets to watch this is going to get something really important out of it because I think it's a very important topic. So I am going to start sharing my screen. And ladies, we are going to start. And there you go. I'm going to put us up in the corner, and then whoever's talking will be showing up. So, this is a lecture that I felt was very important to share with my OBGYN department at Redeemer Health, where I chair quality, safety, and reliability. And the things that I didn't know as an integrative physician and breast cancer surgeon, I feel that my doctors really could benefit from this educational process. So my granddaughter, Margot, is my teacher. She's amazing. She is just coming up on being 4 months old. And my beautiful daughter-in-law started her prenatal vitamins, which we recommend everyone do. But she was given a suggestion of a prenatal vitamin with folic acid, preconception. What's interesting, and now hindsight is 2020, she had been on birth control pills and had pretty good control of her acne. But when she went on the folic acid, she had a severe outbreak and had acne pretty much through her pregnancy, which I thought was kind of interesting. At 14 weeks of her pregnancy, they found out that she had a single umbilical artery, which I have not been able to find any data to connect all of these things, but I find it very interesting because the umbilical artery is a midline structure. Margot had a difficulty latching, and they told her to use nipple shields, which she soldiered through and spent 30 to 40 minutes breastfeeding because she knew the importance of it. And she was told by the lactation specialist at the hospital and the pediatric nurse practitioner that Margot did not have any issues or tongue ties. And we come to find out that indeed she did have tongue ties, lip ties, and cheek ties. And Alex knows the importance of breastfeeding and really wanted to follow through with breastfeeding. So interestingly enough, we went down our path and we were given a wonderful referral to a lactation specialist who is also an occupational therapist. So I recommend as a breast cancer surgeon that my patients, whenever they're going to have children, that they breastfeed for at least 6 months. The inability for my granddaughter to be able to latch was a real concern for me. And I, was watching them connect, and I knew that she needed extra help. And nothing short of an angel, a nurse at the hospital where my daughter-in-law delivered, gave her Kelsey's cell phone, Kelsey's number to her business. And when Alex was having issues, I said, I think you really need to call. I have not met an occupational therapist that did lactation, but to me, it was all in, and I'm there. So what happened was I started to do a deep dive on tongue ties and folic acid and 5-methyl tetrahydrofolate and DNA synthesis, and come to find out that, we've been recommending folic acid for neural tube defect prevention. But unfortunately, folic acid in synthetic form has to be converted to an active form of 5-methylfolate. 1996, I didn't know this either. U.S. Food and Drug Administration recommended adding folic acid to enrich flours, breads, cornmeal, pasta, rice. So pretty much you can't get away with it. So you get a lot of plain folic acid in life as well. Fast forward, I come to find out that my granddaughter and my daughter-in-law have MTHFR, which is it's a methylene tetrahydrofolate reductase. MTHFR, if you say it really fast, it sounds like a bad word. It is a single nucleotide polymorphism, and approximately 45% of the population carries this polymorphism. And specifically the C677T and the A129A8C are can be pathogenic and they can lead to the inability to clear toxins. So unmetabolized folic acid increases homocysteine. It can cause all kinds of medical problems. What's interesting is when I realized that once I tested them for this, my daughter-in-law stopped her folic acid supplement. And sure enough, within days, her skin cleared up and has not been so clear since the time that I have known her. So I had to take a deep dive. So I went into looking at the hazards of excessive folic acid intake if you have an MTHFR gene. And what I found out in the obstetrics and gynecologic literature is that, they recognize that about a third of the world's population has some form or one of the two alleles of the MTHFR SNP. Coronary artery disease is a side effect from the buildup of homocysteine, causing damage to blood vessels, including atherosclerosis. And the unmetabolized folic acid is linked to immune dysfunction and increased risk of cancer and increased risk of thrombosis and clots that can lead to miscarriage. And that at high doses, it can impair natural killer cell function. So you're actually beating up your immune system. So I took another deep dive. Another study out of France and a study out of the country, Georgia, showed that women that were having infertility issues, some of them trying 3 to 5 years to conceive, when they were tested, one or both parents had the MTHFR SNP. And after switching from folic acid only to 5-methyl tetrahydrofolate for 2 to 4 months, 90% were able to conceive without really a lot of difficulty. Some of them required IUI or IVF, but these are women that have been going through these IVF treatments for 5 years. In Georgia, 22 patients with recurrent miscarriages, which is also a sign of infertility, or failed IUI or IVF were tested and found to either be heterozygous or homozygous for the MTHFR gene. And when they were started on 800 micrograms of 5-methyl tetrahydrofolate, 100% conceived naturally. So, I'm wondering how many women in the world and in our country are diagnosed with infertility and actually just need to switch supplementation. So this was the icing on the cake test for me, looking at folate insufficiency, where they actually tested lymphoblastic cell lines for folate response based on the MTHFR. And if you look at this slide, you can see this one little tiny methyl group is the only thing that makes the difference. Being able to go from folic acid to 5-methyl tetrahydrofolate is the issue. So when they took cells that had low MTHFR activity, gave them folic acid, they had a very poor response. Folic acid supplementation in regular people that don't have the MTHFR gene, they increased their 5-methyl tetrahydrofolate 2.5 times. But after folic acid supplementation in people that have the MTHFR mutation, there was absolutely no activity. So once they switched it and gave 5-methyl tetrahydrofolate, the intracellular folate level went 10 times more in these cells of the people that had the MTHFR gene. So this is enough reason just to stop using folic acid and use methyl tetrahydrofolate. So when we look at the genetics, we look at the exposure of folic acid in the population, where we are given foods day in and day out that have folic acid. So we're basically poisoning people that have the MTHFR gene. So there's a hypothesis that impaired methylation due to the MTHFR and leading to unmetabolized folic acid interferes with midline tissue development. It's a lot of speculative data, but more and more integrative practitioners are recognizing this connection. I wonder, was the single umbilical artery related? I clearly know that the skin impairment in my daughter-in-law from taking folic acid, and I'm watching the difference in just 2 weeks. Also, my granddaughter having all those ties, the cheek ties, tongue ties, lip ties, and the practitioners that observe these ties pretty much recognize that they coexist with the MTHFR. And it's actually why, after an appointment with Kelsey, that I actually did the genetic testing on my daughter-in-law and my granddaughter. There was one study out of Israel that was very interesting, out of Jerusalem, that looked at preconception folic acid, had a 3.4 time increased risk of tongue ties. But unfortunately, they did not look to see if these people carry the MTHFR mutation. And to me, this is something that we really have to take the deep dive to get to the bottom of this. So If you do a Medline search and you look at a systematic review, they said there's no clear evidence between folic acid supplementation, but again, they did not look at the MTHFR association. When 30 to 40% of the population has this mutation, we've got to take the deeper dive and answer the questions. So what we see is functional medicines, myofunctional therapists, pediatric dentists, they're finding it. More research is probably needed because a lot of the evidence is anecdotal, but up to 45% of infants with tongue ties are reported to have MTHFR. So I think it is imperative that we as clinicians make this connection, show that how we can prevent it, and really help a lot of patients. So now I'm going to turn it over to Kelsey Baker, who I think is a goddess of therapists. I started working with her with my granddaughter and my daughter-in-law, and by far one of the most positive experiences that I've had in healthcare in a very long time. So thank you, Kelsey.
Thank you so much. I'm so grateful that we were able to connect, and I think we were meant to do this, and Margot is all of our teachers. So very happy to be here. But I think something that gets missed in relation to tongue ties is that it's not just an oral issue. It is a whole body impact. So when someone comes to me with feeding difficulties, for the most part, I'm doing a full body assessment. And within the first 2 minutes of our time together, I'm looking at what their body is like. Are there any asymmetries? What's the facial presentation? What's the breathing pattern? How is the skin? What is our overall alignment and posture? And that is in relation to where our ribs are over our pelvis, as well as what does our mouth look like? Are we breathing through our mouth or breathing through our nose? And how regulated are we? Is this a baby that goes from 0 to 100 and is very easily dysregulated? Or are they able to kind of show signs of early dysregulation so that we can co-regulate with their caregiver more easily? All of these things are very, very important when it comes to working with tongue ties. So when a baby comes to me, I do this full body assessment. So I go over reflexes. Reflexes are something that aren't talked about enough, in my opinion. We really need to be screening reflexes frequently at birth, at our first few well visits. I think that every baby should be working with an OT who understands reflexes because there's so many impacts on how we express those reflexes. So I'm looking at the quality of movement, the speed of response, and what is the quality of response. So sometimes when I am trying to elicit a reflex and it's not happening, it's not necessarily a neurological issue, but because of birth trauma or compression or medication or any number of factors, those signals can be kind of muted. And I will describe it as kind of like a fuzzy radio signal or fuzzy, like black and white screen on an old TV where, something's coming through, but it's hard to make out. I'm also looking at cranial nerve function. What is the symmetry? What is the coordination of their facial movements? And what is also our vagal tone? That vagus nerve is a big piece of this. I'm looking at the fascial strain and body alignment, functional movement, and overall development. A lot of times, especially for these older babies at 2, 3, 4 months old, I am not seeing enough head control, and that's indicative of poor core stability that's going to make feeding harder. So sometimes it really is looking at the foundation before we can get to the fine motor movements of feeding and of the mouth. And then we get to the oral assessment. So I'm not qualified to officially diagnose, but I've been doing this for a while, and I will walk through what I'm seeing with families. What are the tissue restrictions? What's the range of motion? And how accepting is this baby of input into the mouth? And it's not just about the fascial restrictions of the ties, lip, cheek, tongue, but it's also the muscular tension that is aiding in this compensatory strategies that a lot of babies come to me with. So there's a lot of signs of tethered oral tissues, and they're all lumped under oral dysfunction because many times someone will suspect a posterior tie or some level of restriction, but there's something else going on, and it goes back to reflexes, strength, endurance, coordination, cranial nerve function, all of the other things that I listed. So these are all kind of part and parcel of potentially having a tie or not. And it also ties into that MTHFR gene variant that makes it tricky for methylation and how well our cells are responding to activation and how readily they are to respond. So babies with oral dysfunction have difficulty with breast and bottle feeding, typically, usually one more than the other. And a lot of times we hear about breast difficulty, but I see just as much bottle difficulty. So trouble latching and staying latch, sliding off the breast or bottle nipple, clicking or smacking, lots of air intake and poor seal, long, inefficient feeding sessions that are really dragged out. And it's really hard to make sure that they're getting enough when at the breast. Sometimes this is correlated with the maternal nursing pain, nipple pain, blanching, damage due to a shallow latch that would lead to using a nipple shield like Alex needed to because there was so much tissue damage because Margot wasn't able to get a nice deep latch. And that can also lead to recurrent black ducts or mastitis if baby isn't able to transfer milk easily and milk stays stagnant in the breast tissue. We have a higher likelihood of having clogs and eventually potentially mastitis, which is not going to be helpful on our feeding journey. Restricted tongue movement is a big piece of this, of course. If the tongue isn't able to elevate and create suction to the palate, it can't do its full job. We have our tongue is our built-in palate expander. So if it can't elevate and create that lingual seal to the palate, it can't actually help shape the face. So the tongue tip may look heart-shaped or notched when extended. A lot of people will say, oh, they can stick their tongue out. They don't have a tongue tie. That's not necessarily true. I know lots of babies with tongue ties that can stick out their tongues actually pretty far, but we need to see that it can do its full job of elevation, extension or protrusion, lateralization, cupping, and go through a nice peristalsis of swallow pattern to create a uniform pressure on the palate as well. Um, a lot of babies with tongue ties and oral dysfunction have open mouth posture at rest. So they end up breathing through their mouths more frequently than we would like. And that can lead to a lot of difficulties. There's so many longer term things that are impacted. But in the moment of mouth breathing, we are not filtering our air as well. We're not making as much nitric oxide, and we have a higher inflammation of our tonsils and adenoids as we're breathing through our mouth rather than our nose. That will also impact how our palate develops and the angle of our eustachian tubes and can potentially lead to more chronic ear infections and this kind of cascade of events that we don't want. This can also be poor weight gain and feeding fatigue. So it's just really hard for baby to finish a feed because they are working really hard and fighting against those restrictions, that tethered tissue that kind of acts like a resistance band. And sometimes they can do really well, and sometimes they just don't have enough gas in the tank, which goes back to methylation and also is really confusing for families where sometimes they can do it and sometimes they can't. So that slow or inadequate weight gain, despite really proper feeding attempts, is a big sign here. Other indicators that OT would be supportive of feeding and development is pretty much everything that we're seeing on the day to day. Induction, vacuum, cesarean, excessively long or short labors when babies aren't exposed to that nice pressure of delivery. It doesn't allow for reflexes to fire as well. And that is how we kind of wake up the brainstem and it starts everything. So especially when we have an induction and baby isn't starting that sequence of events and a medication is, it can make things a little trickier on the other side. Uh, Any NICU time is also going to be indicative that occupational therapy is going to be supportive of this baby. Even if they are medically stable, we're looking at that quality of life component. Any asymmetries or C curve, head turn preference, any cranial molding difficulties, difficulty latching initially, of course, inability to have the first few hours after delivery with the parent, because that skin to skin and access to colostrum is so, so vital for an easier feeding journey. And we know that that's not always medically available, but in an ideal world, that is available to everybody. The big part about working with babies that may or may not need tongue, lip, or cheek releases is that they need to be prepared for the release. It is almost never the first step. Ideally, we are preparing their body therapeutically to be more regulated, be more symmetrical, know what to do with their current range of motion and anatomy, so that when they do have more range of motion and more access to that, they're able to regulate through that discomfort more easily and actively participate in the rehab necessary to relearn how to use their tongue and go through that neuromuscular re-education. The one scenario that I do see release being appropriate first would be if there's a very clear anterior tongue tie where we need to do a quick snip release with the education that that is the family's first step and more support is going to be required. It's very frustrating for the families when they come to me at 3 to 4 months saying they had the tongue tie taken care of, and there's still all of these other issues that we potentially could have avoided a lot earlier if we had had that conversation and that understanding that there was still more to be done. So that's kind of the one caveat, and then potentially needing a full release later on, maybe not. Working with a therapist who is trained in lactation, bodywork principles, and understanding infant development is really the best way to make sure that they are adequately prepared for release. We have good tissue differentiation. The muscles are more relaxed and able to be strengthened. When we take away the stability that the fascial restriction is providing, and we don't have the ability to replace that stability with strength, we can sometimes lead to bigger issues, which is where I come in, but also where I'm working closely with a release provider like Dr. Joanna.
So, Kelsey, before I switch it over to Dr. Joanna, I will tell you that literally the night before Alex's first appointment with you, she was starting to develop engorgement and
Mm,
she had clogged ducts. And I end up seeing a lot of postpartum women with mastitis, galactoseals,
mm,
and the things that are like secondary to babies not being able to latch and completely empty the breast.
yeah.
And my heart was breaking for her because all she wanted to do was be able to feed this beautiful child. And it was so much work. The baby would get fatigued. And like everything that you're talking about, I feel like we were walking through these step by step by step. And I am so grateful that because I didn't know you. I am so grateful that this nurse from her hospital where she delivered said, if you have difficulties, you need to go see this person.
Mm,
And even after the first visit, and you being able, and I jokingly, and like my next book just went to print today, ladies, by the way. And when you read the chapter that you're in, Kelsey, like I do describe the baby waterboarding, which is can't be described as anything else but that where women think they're gonna like suffocate their kid because they have to hold them so close to get them to latch. And it's different for you to do it with Margot and my daughter-in-law than me because I'm gonna look like I'm not an expert in lactation. I'm only a breast cancer surgeon. So you being able to do it and then me being able to help her walk through those steps to be able to start that process was such a big deal to be able to prevent mastitis. I mean, mastitis and galactoseals are not fun.
mm,
So thank you for all of that.
of
And
course.
after I think it was a month of therapy, I'm pretty sure it was about a month,
Hmm.
that you were seeing Margot. What made you at that point say, okay, it's time to go see Dr. Walska?
Great question. I mean, working with Margot, we had started with Nipple Shield, and in that evaluation session, we were able to get latched onto bare breast, which was amazing. And we had a reasonable transfer. I want to say it was an ounce and a half, if I remember correctly. But at that time, that was a huge win to be able to latch at all without the Nipple Shield. And Margot was really doing pretty well. I wanted to see how that was going to play out if we actually needed to have a release. And we also needed to do some body work to release some tension, work on some side preference patterns that Margot had, and also just get in the swing of feeding rhythms between Margot and Alex.
Got
And
it.
then when we got to that 4 week mark and we had made good progress, but we weren't where we wanted to be. And I could see that Margot was getting very fatigued, the popping on and off and kind of frustration that she exhibited when the flow would slow down, right? A lot
Yeah.
of babies with ties will quote unquote ride the letdown. They'll take the milk that is really easily available and they're not working to actually empty the breast. And I could see that Margot wanted to. She had the desire to, but she didn't have the strength to continue all the time, and she needed lots of breaks. So that's when we see this snacking behavior happen a lot. And like my breastfeeding journey, my daughter was snacking all the time because I just didn't know all the things I know now, and that's how I needed to feed her. But I wish I knew all the things I know now, and it would have been a lot more efficient for everyone.
So it was interesting when Alex called me and she said, we're going to go see a holistic dentist, an integrative dentist in Newtown. I'm I'm a surgeon and I do surgical procedures all day, every day. And I always thought that you would go to an ENT surgeon. And I was kind of excited because when we got referred to Joanna, she's like 3 miles from my old house, right in the right neighborhood. And I'm like, besides the fact that I went online, I looked at her picture and like, who could not love this smile? And this beautiful woman who, when I walked into her office with my daughter-in-law, I instantly felt like I said, okay, God brought us to the right place. This is divine intervention. This is a woman because her daughters were running around the office. I loved it. I just felt like here's a working mom like me who's doing everything that she needs to do to be there for her kids, but who gave so much to her patients. So, Joanna, thank you again for like welcoming us to your office and talk to us about the office laser frenulectomy because I didn't know anything about it. And it was very interesting because when my daughter-in-law called to make the appointment, they said, well, Dr. Walska can't see you till Thursday because she's at a lactation conference this weekend. And I'm like, well, there you go. I'm all in.
Yeah, so as you guys called me, I was taking a lactation course out in Connecticut. It was a week long, and that's just how I work. I want all the answers. A lot of times when we do this, it goes into the interdisciplinary fields, and I'm just because other dentists didn't go there to that course, I feel like I need to understand the parts of the lactation to be able to see, is this patient ready to be released? And, I always send them to good providers. Some will go, some won't. So at least I can give them some tips on maybe positioning and other things to try. Because most importantly, after the release, we want to make sure that they're breastfeeding well so that it doesn't reattach. It's that natural kind of stretching and exercising. But yeah, so why we need to do this early? Um, it is the breastfeeding challenges I won't go into again, but it also can affect speech. So as kids, if they have that restriction, if it doesn't get released as they are learning to speak and those milestones that they're passing go away, then they are left with a problem with articulation. That tongue just doesn't reach the palate the way that other people's tongue does. And so um, then they think that that's how they're supposed to say words. So speech therapy helps, but a lot of times even speech therapy, they reach kind of this plateau where they can't progress further. And so at that point, then they have to get the release, unlearn how they've been speaking, and probably do expansion. So with growth in airway, if the tongue is not on the palate, it's not growing the palate. When they're older, we can't just do a release because there's no room in the palate for the tongue to go now. The teeth have collapsed. The tongue is kind of over on top of the teeth when they try to suction their tongue up to their palate, if they're able to do that. And so if they get a release before there's enough room in their palate, again, it's going to reattach because their tongue is going to want to sit low because there's just no room in the palate. So if you do this early, you can prevent those teeth potentially from collapsing so much, and then the growth and development can be like nature intended. So the in-office procedure is really quick. There's no general anesthesia. There's no sedation. If the baby's under 1, we don't even numb them because of methemoglobinemia. But if they're over 1, we could put a little bit of topical and numb it a little bit. I have an I have an 1064 laser first that I use for photobiomodulation. Sometimes when I use this laser, the frenectomy is not needed because it can soften up that fascia. It can wake up certain nerves that have been sort of sleeping because the energy from the laser gets transferred into their nerve, and they can sort of realize, oh, I could put my tongue up here on the palate. And so it seemed like a posterior tie maybe was a restriction. So if we really relieve that restriction, we can avoid the frenectomy.
I'm
The
going to tell you,
CO2 is the,
Joanna,
yep,
that laser, just watching, I mean, I work with the vagus nerve all the time. I'm very, obviously I'm very much into integrative medicine because that's what I do in addition to breast cancer. But that laser's level of relaxation, it was visible, it was palpable, and then that actually translates into the mom as well.
yeah.
I'm sure you see that as well.
Yeah, I do recommend moms get it as well. And, I think that that is the goal, to be able to do it on both mom and baby on every patient. But yeah, I mean, it's really that posterior pharyngeal wall is picking up all that energy from the laser, and that's where that parasympathetic tone really it gets upregulated. So yeah, I have kids who come in, and I do this after I do the alpha, which is that gentle palatal expander, and the parents call me the next day and in tears, they said, "This is the first night my child has slept through the night." And yeah, so it's really awesome. If they do need a release, we have the CO2 is the gold standard. That's what most people use to do the release. It's great at controlling bleeding, so there's a great field of view, and it's quick. The only downside to that is that because it's so quick and because it's so hot, it can cut through multiple layers of tissue. So if there's a very thick tie, I've been using the blue light laser, which is more precise. It has less collateral damage, and so overall faster healing. It's more gentle, and we don't cut into the musculature of the tongue, and that helps with the healing. It helps with the function, and so that's what I would use if it was a thicker tie. And the recommendations I have are really to recognize this early. If we can get that tongue functioning and getting up to the palate and suctioning, it not only helps with the palate expanding into the proper width that it's supposed to be, but also when the tongue suctions up to the palate, it brings the mandible forward. So this encourages both maxillary and mandibular growth. Ideally, this is a team-based approach. We cannot do a release unless they are ready for the release and they are trained and taught how to do stretches and exercises afterwards so that it remains supple and it doesn't reattach. And it is extremely safe. It's very minimally invasive. I think the slight pain for a few days after the procedure really outweighs the multiple visits that would be needed later. And if the tie has to be released later in life anyway, then it's not as a quick of a procedure just because then there's deeper tissues involved, and most often sutures.
So obviously the clinical implications are huge for this. This is it's a big deal. From the beginning of the MTHFR mutation and folic acid being utilized, leading to miscarriages and infertility, and also leading to midline issues with tongue ties. And like I said, I'll never be able to prove whether or not the single umbilical artery is related, but I got to think that it was. I can't imagine that it's not, but nobody studied it. We recommend to our OBGYN colleagues to use 600 to 800 milligrams of methylated folate, 5-methyl tetrahydrofolate. There's no reason to not use it. Folic acid, if it's not converted, you're basically giving somebody something toxic. You can prevent neural tube defects, help prevent miscarriage, and not injure MTHFR carriers. The other thing that I think is really important to recognize is that the food sources in the United States of America have all been enriched. If it says it's enriched, it means it's got folic acid. And folic acid in someone that can't break it down is not good at all. Early referrals, if a baby is having trouble latching, you don't know what the issue is, so you've got to go see someone. I would highly recommend it if you're in Philadelphia, you're going to go see Kelsey because she was amazing, and I think that she should be teaching OTs and lactation consultants all across the country. I think that she's going to go wide and far because her love of what she does and how she does it is amazing. Same thing with Joanna. Like I feel like God has brought me to the right place at the right time with the right providers because these women truly care about what they do. And